Hello, everybody. This is Richard Polin speaking to you from just side of New York City from my home. I'm delighted to be speaking today about a topic of great interest to me, and that is neonatal sepsis and the issue of antibiotic stewardship. Now, I know there's a lot of expertise in the individuals listening to me since rule-out sepsis is one of the most common diagnoses we have in the NICU. But if I ask you what is neonatal sepsis, some of you might say, well, that's pretty obvious. That's what we culture or what a molecular diagnostic test is telling us. But others might say, I know when I see it. And that phrase actually did not come from a physician. It came from this individual, Potter Stewart, famous Supreme Court Justice in the United States. And he was asked, what is pornography? And Dr. Stewart or Mr. Stewart said, well, I know what it is because I know it when I see it. And that's how a lot of clinicians approach the issue of neonatal sepsis. But sepsis is not always obvious. This is the case recently for my own NICU. It's a 32-week gestation born by emergency cesarean section. There was prolonged rupture membranes for 18 hours. The mother got a single dose of ampicillin because of a rapid test positive for group B streptococcus. APGAR scores were 89, and the infant was sent to the well baby nursery where he roomed in with the mother. The infant breastfed successfully and had a normal screen, which we do in our well newborn nursery, at 60 hours of life. But later on the third day of life, the infant was found to be pale and unresponsive. He was rushed to the NICU, where he was immediately intubated. They got a blood culture and started broad spectrum antibiotics. There was severe metabolic acidosis, a white count that was slightly elevated, with 15% band forms. The C-reactive protein was elevated. All cultures were subsequently negative, except for a placental culture growing group B streptococcus. And this was a surprise at autopsy. Baby did not die from sepsis. Cultures were negative. The baby died from coarctation of the aorta, which might be missed on a screen for congenital heart disease. So I have two objectives today. One is to provide a rationale for antibiotic stewardship in the NICU, and lastly, try to provide some supporting evidence for my comments today. We all like to see evidence, and there's a famous quote by Carl Sagan when he was talking about life on other planets. He said, absence of evidence is not evidence of absence. We don't always know whether there's life on other planets just because we can't detect it now. And I would say my corollary, or not so sophisticated, is evidence is not all it's cracked up to be. Let me start with some numbers about sepsis in bigger babies. Sepsis is a pretty uncommon disease. In the term population, it's about 0.5 to 1 per 1,000 live births. But in well-appearing term and late preterm babies, the incidence is much lower, 1 in 25,000. Therefore, as you'll hear me say later on, even if there are major risk factors for infection, such as chorioamnionitis, those babies are very unlikely to have an infectious episode and can just be observed. Sepsis workups are far more common than proven sepsis, and we do them because babies there are demonstrating clinical signs but have non-infectious diseases. Having said how rare sepsis is, it's still a major cause of mortality in the NICU. And if you look at the yellow and purple bars on the lower right part of the slide, you see that sepsis accounts for about 12% of all mortality in the NICU. When we think about our very low birth weight population, the numbers are very different. In VLBW babies under 1,500 grams, the incidence of sepsis is about 9 to 11 per 1,000 live births, or about 20 times higher. 75% of deaths for sepsis occur among those very low birth weight babies, and up to 90% of VLBW infants receive broad spectrum antibiotics for possible sepsis. And we know, and I'll go over some of these studies, that if babies are treated for more than 5 days, which is commonly used, it's associated with a number of neonatal morbidities. These are relatively recent data, I guess about 5 or 6 years old now, on a large database looking at the duration of antimicrobial therapy in VLBW babies. And though the average time is about 3 days, as you can see in this graph here, many babies are treated for periods considerably longer. So the question for all of you to think about, and for me to tell you about, is how to identify the infant with clinical signs or risk factors who is infected and avoid treating others. In other words, just like finding a needle in a haystack. The corollary for that is, can we safely decrease antibiotic exposure in newborn infants at lower risk for sepsis? And there are three opportunities. Two of them have been proven, I think, with substantial data. One is healthy appearing late preterm and term infants, at least 35 weeks gestation, with risk factors for sepsis, including chorioamnionitis and intraamniotic infection, but that's a population that does not need routine antibiotics. Second population are preterm babies with no risk factors for infection. That's born by elective cesarean section for maternal indications such as preeclampsia, with either artificial rupture membranes or rupture membranes at delivery. And the third is controversial, and that is preterm infants with other risk factors for infection, other than chorio, which may or may not need treatment. And we're currently studying that with a randomized clinical trial called NANO, neonatal antibiotics and outcome. We've so far enrolled about 300 babies. But the diagnosis of sepsis is not straightforward. Sure, it's a positive blood or CSF culture. That's how the CDC defines it, Centers for Disease Control. But there are babies who have transient neonatal bacteremia, of a positive blood culture, and then upon a repeat, even as short as 12 hours later, that blood culture is negative. How to interpret blood cultures for common skin contaminants, such as coagulase negative staphylococci, which are common pathogens for late onset sepsis, but not for early onset sepsis, or babies with polymicrobial bacteremia, which suggests contamination. And then, does an infant with signs of sepsis, including multi-organ system dysfunction and laboratory evidence of systemic inflammation, but a negative blood culture, meet the criteria for sepsis? If you're talking about pediatric or adult sepsis, it certainly would. But I think the answer is no for a neonatal sepsis. So culture negative sepsis occurs in an infant who's being evaluated for sepsis, has a negative blood culture, and signs or symptoms of and ancillary laboratory values that are concerning for infection. Culture negative sepsis is common. In the US, it's 16 more times common than culture positive sepsis, and middle and low income countries, it's 50 times more common. What are the causes? Well, it could be a non-infectious sepsis-like syndrome. For example, a baby with asthma meconium aspiration, which is frequently non-infectious. Or it can be due to physiologic instability due to prematurity, especially hemodynamic instability or lethargy or a decreased muscle tone. Pre-treatment with antibiotics, I put a question mark next to. I'm going to show you data that maternal antibiotic treatment is probably not relevant. Is it a focal infection without bacteremia, such as necrotizing enterocolitis, osteomyelitis, or urinary tract infection? Probably fairly common. Is it a viral disease? In the summertime, we see viral sepsis in our NICU, or fungal sepsis. Or is it an anaerobic organism or fastidious organism that is not easily cultured? Or it might be an unculturable pathogen, only detectable by molecular methods. And importantly, there has to be a sufficient volume of blood to detect early onset sepsis. And for me, that volume of blood is 1 ml. But having said all that, most blood cultures obtained on day 0, 1, or 2, which is really the days for early onset sepsis, are negative. In fact, 98% in this large database of over 600,000 babies were negative, and only 2% were positive. Does treatment of culture negative sepsis have consequences? I'm going to show you a couple of studies, but with one caveat. There are biases in the study. So the babies who received antibiotics were sicker, and the authors have to control for the degree of illness among the control infants. So let me show you the studies. The first is by Shi, published in JAMA Network Open in 2024. It's data from a national registry of babies under 1,500 grams, under 32 weeks, at low risk of infection because they're delivered by cesarean section without labor and rupture membranes and no chorioamnionitis. But some of the babies were treated with antibiotics, probably the sicker babies, and they looked at day 0, day 1 to 4, and day 5 to 7. The primary outcome was moderate to severe BPD or mortality at 36 weeks post-conceptional age. And they concluded, after adjustment for confounding variables, which is not easy, prolonged antibiotic therapy defined as more than 5 to 7 days increased the risk of BPD or death. Those are the odds ratio. It's quite significant. Compared to infants not receiving antibiotics, there was no significant effect on mortality. Broad spectrum antibiotics given to this population in general of any duration increased the risk of BPD. That was not true for narrow spectrum antibiotics. And each additional day of antibiotic exposure the first week of life was associated with a 10% increase in the primary outcome, which is BPD or death, and 10% increase in BPD at 36 weeks. And especially the dose-response relationship, this last bullet point, suggests to me that there may be an important relationship between prolonged antibiotic therapy and death or BPD. And then there's the secondary analysis of the EPIPAGE 2 study. And then early antibiotic therapy was defined as treatment on day 0 to 1. The N was 648. And they did not look at duration and type of antibiotic. The control population received no antibiotics and was chosen for their lower risk of early on sepsis. Compared with control infants who did not receive antibiotics, treatment was associated with a higher incidence of moderate to severe BPD. But interestingly, not late onset sepsis or necrotizing enterocolitis, which has been previously reported. So here's my algorithm for managing early onset culture negative sepsis. So if you have suspected sepsis, you draw a blood culture, and you should draw at least an ml. If the baby is clinically improving, stop antibiotics no more than 36 hours. If there's no clinical improvement, if the baby is actually critically ill, broaden the coverage. Consider lumbar puncture. If the lumbar puncture is negative and it's a really sick baby, treat for at least 5 to 7 days. If the lumbar puncture is abnormal, treat for 2 to 3 weeks, which is what we do for meningitis. And remember, some of those babies with suspected sepsis have either viral sepsis or fungal sepsis, rarely, or a focal infection that does not manifest with a positive blood culture. But these are the culprits in the US at least, and they're ampicillin and gentamicin. I know that gentamicin is not frequently used in China, where third-generation cephalosporins are more commonly used. And if you ask clinicians in our country why they like to use antibiotics, this is how they respond. Routine usage of antibiotics in high-risk infants had decreased mortality and morbidity. There are few or no downsides to broad-spectrum antibiotics of any duration. Clearly, both those statements are incorrect. If it is good for children and adults, it must be good for babies. That gets us in a lot of trouble. Laboratory testing can pinpoint which infants need antibiotics, at which they did, but they do not. And that is what we were taught. If the guy teaching you about sepsis looks like this guy, don't listen to him. If the guy teaching you about sepsis looks like this individual, who's a very famous neonatologist, his name is Bill Silverman. He's the father of evidence-based medicine. And in 1949, he wrote this: the diagnosis of septicemia should be suspected in every newborn who is obscurely ill. It is clearly that a complete history of physical and laboratory data should give an early diagnosis. It should, but not always. It is justifiable on the basis of reasonable suspicion alone to begin vigorous antibiotic therapy. And I put the sulfadiazine in blue, along with penicillin and streptomycin, while awaiting culture confirmation. I put it in blue to highlight it because that was a major cause of kernicterus in the United States, because as you know, sulfadiazine, sulfur compounds, displace bilirubin from albumin. Let me talk about screening laboratory tests and give you another case. This is a 1 kilo infant, VP, born at 27 weeks gestation, delivered by cesarean section for maternal hypertension. That's obviously a low-risk group. Membranes ruptured at delivery. The infant got some positive pressure ventilation by an overconfident intern DT and was placed on CPAP with 45% oxygen. The abnormal signs completely resolved in 4 hours. Baby looked well. Infant's white count was 6,000 with 30% neutrophils and an IT ratio of 0.25. That's immature to total neutrophil ratio of 0.25. The platelet count was 80,000, clearly low. And here's our baby VP, looking very happy. And here's our overconfident intern, who, as you know, is one of the candidates for presidency in our upcoming election. So how would you manage this infant? It's a well-appearing baby. Obtain a screening blood culture, but withhold antibiotics. Begin broad-spectrum antibiotics after obtaining a blood culture and CBC, or provide supportive care with no additional testing. And I hope you all chose provide supportive care. This is considered a low risk infant because of the risk factors the baby has born by cesarean section without ruptured membranes. Remember, screening blood cultures in lots of studies have a poor positive predictive accuracy and fail to identify infants with early onset sepsis who appeared well at birth. Remember, 98% of blood cultures for early onset sepsis are going to be negative. Low white blood counts, leukopenia, low absolute neutrophil counts, neutropenia, and high immature to total neutrophil ratios are associated with proven infection, but are of minimal value in deciding which babies need antibiotics. Of all those things, low platelet counts are the least helpful index. I'm going to show you one of my favorite studies. It's not new. It's about 12 years old now, but I think I would say it's a definitive study on various neutrophil indices in sepsis. The population includes 166,000 from the pediatrics medical group, including term and preterm. Only about 1% of the cultures were positive. In the infants with positive cultures, 60% had a white blood count between 5 and 19,000. 87% had a normal absolute neutrophil count greater than 1,500. And only 30% had an IT ratio, immature to total neutrophil ratio, less than 0.2. The sensitivity of the immature to total neutrophil ratio, which is felt to be the most sensitive index for babies less than 34 weeks, was only 65%. And here are the data graphically. The left side of the slide looks at IT ratios or varying IT ratios on the y-axis and odds ratio for sepsis on the x-axis. And the right graph looks at absolute neutrophil count. So looking at the graph on the left, until you get to very high IT ratios, more than 0.25, the risk of sepsis does not increase. So at the extreme, the risk of sepsis goes up. Here are the odds ratio for sepsis. On the right side are absolute neutrophil counts. And again, until you get down to very low absolute neutrophil counts, the risk of sepsis is not affected by the ANC. At very low ANCs, the risk of sepsis is increased. In this study by Tom Newman, who practices out in California, looked at the combination of absolute neutrophil count on the x-axis and infectious risk. The varying IT ratios are shown in different colors. So you can see here at the low absolute neutrophil count, the lowest ANC, the risk of sepsis is markedly increased up to about 20%, except when the IT ratio is really in a normal range. As you start to go with higher absolute neutrophil counts, the risk of sepsis goes down, but the higher IT ratios always increase the risk for sepsis. So the two are synergistic, looking at sepsis, both ANC and absolute neutrophil and IT ratio. And this is from a recent publication by Sergio Mucopatier and Karen Popolo, looking at the value of white blood count in well-appearing babies with risk factors for sepsis at varying times. All these babies are more than 35 weeks gestation. Abnormal CBCs greatly vary, but you can see the percent with sepsis is far less than 1%. How about biomarkers? None of the biomarkers, meaning C-reactive protein or procalcitonin, have a high enough sensitivity or specificity to be clinically useful. I used to love CRP, not anymore. Early determination of acute phase reactant is of limited utility since lots of other conditions elevate CRP, and I've listed some of these on the slide here. And CRP takes about 12 to 24 hours to be reliable in an infected infant. Procalcitonin also peaks at 12 to 24 hours, rises a little bit sooner. So while the negative predictive accuracy of these biomarkers is high, by the time they can be relied upon, which is close to 12 to 24 hours, the results of the blood culture are usually known, and the baby's either getting better or not. So it doesn't provide any unique information. This is a very recent study by Dudazia et al. In Journal of Pediatrics, a study of over 10,000 late preterm and term infants with an abnormal CRP within the first 4 hours of birth. The sensitivity of CRP was only 41.7%. The positive predictive value was only 2.3%, which means if the CRP was positive, 98% of the babies were uninfected. The negative predictive accuracy is high. Some people use it as a reassurance that their physical examination is normal. And the conclusion of the authors is CRP is not useful to guide decision making at the onset of a sepsis event. What's the best thing you can do? Lay your hands on the baby, listen to the baby's chest, do a careful physical examination. Why is it here? I've given you the clinician's answer why the use of empiric antibiotics is so pervasive. Here's sort of the scientific answer. One, we have a hard time identifying babies with sepsis since the signs are not specific. Most clinicians have assumed that the commonly used antibiotics have few risk factors and serious complications. If you're giving IV antibiotics, infiltrates are certainly a common or can be common in the NICU. And renal toxicity, if you're using an aminoglycoside, maybe it's seen as many as 30% of babies. There's an effect on the microbiome, which I'll talk about, and people don't care about costs. There's two kinds of costs. There's the social cost of separating mothers and babies and placing them in NICU, and the economic costs, which are considerable in the United States, of keeping a baby in a NICU for 48 or 72 hours. And as you know, once we start antibiotics, it's difficult to stop them, especially when you combine that with laboratory testing, which reveals at least one abnormality. There are four pathways by which babies get infected. Two of them are very uncommon, fortunately. Infection from amniocentesis, very uncommon. Retrograde infection from the mother's abdominal cavity. Transplacental infection, are the torsion infections like toxoplasmosis, rubella, cytomegalic inflammation disease, which go through the placenta to the baby's circulation. But most of the early onset sepsis is due to an ascending infection. We're beginning with organisms in the birth canal, which then spread upward into the uterus. So how important a risk factor is intraamniotic infection or chorioamnionitis? It depends on gestational age. In our late preterm return babies, who are at least 35 weeks gestation, the risk of sepsis in mothers with an intraamniotic infection is low. It's probably 1% or less. On the other hand, if you're looking at very immature babies, the risk is much higher. These are data from the NICHD Neonatal Research Network, looking at babies 23 through 28 weeks gestation, and looking at three outcomes. Histologic chorioamnionitis, it's the same as intraamniotic infection. Clinical chorioamnionitis and early onset sepsis. So the margins of viability, at least in my hospital, at 23 weeks, clinical chorioamnionitis in the mother is about 25% or 26%. Early onset sepsis, only 4% of babies, but significant. And if you look at the other side, at 28 weeks gestation, only 14% of mothers have clinical chorioamnionitis, meaning that the intraamniotic infection is silent, and 1% of the babies develop early onset sepsis. The other thing I'd like you to note on this slide is the ratio between histologic chorioamnionitis and clinical chorioamnionitis. At every gestational age, histologic chorioamnionitis is 3 times more common than clinical chorioamnionitis in the mother, suggesting that maybe histologic chorioamnionitis may be non-specific. Now, intraamniotic infection can be overt or subtle. It's overt when the mother develops signs of fever, tachycardia, etc. But we know that before then, organisms can spread upward into the birth canal, and before they enter the amniotic cavity, they can cause a choriodeciduitis. And that may be important because inflammatory mediators from that site can get into the baby's circulation and may be associated with neurological morbidity. Once the organism enters the amniotic cavity, there can be preterm premature rupture of membranes or preterm labor, and obviously chorioamnionitis or the intraamniotic infection is symptomatic by that point. So how do we classify intraamniotic infection? In the past, when an obstetrician used to say, I'm concerned about chorioamnionitis because the mother has a fever, it used to be sort of a routine practice for them to do a series of cultures and start antibiotics. In 2017, the American College of Obstetrics and Gynecology changed their classification of intraamniotic infection from isolated maternal fever, a fever of 38 to 39, suspected intraamniotic infection, which is a fever greater than 39, or 38 to 39 with one additional clinical risk factor, such as a high maternal white count, purulent cervical drainage, or fetal tachycardia. And then there's a confirmed category based on amniotic fluid tests consistent with infection or evidence of placental infection or inflammation. And they said when intraamniotic infection is suspected or confirmed, administer intrapartum antibiotics, but not when it's isolated fever. Which brings me to the topic of antibiotic stewardship as it relates to our preterm babies. What's the real goal of antibiotic stewardship? Some babies need antibiotics. Some babies need lots of antibiotics, sometimes more than two. Antibiotic stewardship is not about giving less antibiotics. It's about giving the right antibiotic to the right babies for the right reasons and clearly at the right dose. In our preterms, it's easy or relatively easy to identify risk factors for early onset sepsis, such as prolonged ruptured membranes, chorioamnionitis, preterm premature ruptured membranes, mode of delivery, race, and gestational age. However, the independent contribution to those risk factors, other than gestational age, is nearly impossible to quantify. That's why there is no sepsis calculator for preterms. In many cases, infection in preterm babies begins before the onset of labor, and that is not as true in our terminally preterm babies. This is a really important retrospective observational study of babies 22 through 28 weeks gestation to identify low-risk infants who do not need routine antibiotic treatment. Low-risk infants are defined as delivery by cesarean section with membrane rupture at delivery and absence of clinical chorioamnionitis, also called intraamniotic infection. High-risk infants are defined as cervical incompetence, prolonged rupture membranes, or intraamniotic infection, and unexplained onset of non-reassuring fetal status. 37% of babies in the database, which was the Neonatal Research Network database, met low-risk criteria, and in that group, the incidence of sepsis was 0.5% versus 2.5% in the higher-risk comparison group. Many babies in the low-risk group were quite ill. They needed ventilation, needed surfactant, may have needed pressors. Therefore, clinical signs are not helpful in identifying low-risk infants. Lower-risk infants had a significantly lower risk, combined risk of death or early onset sepsis. And the Committee of Fetus and Newborn responded to those data. They said in babies less than 34 and 6/7 week gestation, categorize the babies as lower risk or high risk. Low-risk infants do not need a laboratory evaluation or systemic therapy or blood culture. But for infants that do not improve after stabilization, you might consider giving systemic antibiotics because of degree of illness. High-risk infants should have a blood culture and receive empirical antibiotics. Do maternal antibiotics invalidate blood cultures? So let me present another case. A 1.5 kilogram infant, 30 weeks gestation, delivered vaginally with ruptured membranes for 15 hours. The mother has a fever of 38, which is significant. The infant was started on CPAP with 45% oxygen. Chest X-ray looked like RDS. At 36 hours of life, the blood culture is negative. The infant's getting better. However, the intern wants to treat for 7 days, feeling that the blood culture was invalidated because the mother received ampicillin and gentamicin. So here is baby Kim Jae-yu, actually born wearing a pair of glasses. And here's our intern, but not a very smart intern. He doesn't know that the stethoscope goes on the chest and not on the head. And by the way, I just want to make you know that I am a Democrat. I would never vote for that individual in 1,000 years. So how long did you treat this infant? 36 to 48 hours, 5 to 7 days, regardless of laboratory testing, or 5 to 7 days, only if the CRP is high or the white count's greater than 30,000. And I hope you're all thinking only 36 to 48 hours. This is a really neat retrospective observational study, 70,000 babies, which they try to get an ml of blood culture for each baby. There were lots of contaminants, 63% had contaminants. The time to positivity was not affected by maternal antibiotics. This is everybody. So by 36 hours, more than 90% of the cultures were positive. If they separated it into pathogens and contaminants, by 24 hours, the pathogens had grown. The contaminants all grew out much slower. And when they looked at the effect of intrapartum antibiotics, on this graph over here, the dotted red line is intrapartum antibiotics. Solid blue line is no intrapartum antibiotics. Absolutely no difference giving intrapartum antibiotics to the mother. The authors estimated that using 36 hours at the time for empiric antibiotics would have avoided over 3,500 doses of unnecessary antibiotics. What are the unseen risks to routine use of antibiotics? And they relate to the microbiome. The microbiome in the baby is affected by factors in the mother. If there's organisms in the amniotic fluid and the baby swallows them, obviously that can help colonize the GI tract. Does the mother live in a rural or an urban environment? What's her diet like? Did she receive antibiotics? And postnatally, was it a vaginal birth or cesarean section? Was the baby breastfed or given formula? What was the baby's antibiotic exposure postnatally? And was the baby cared for in a NICU environment or a routine nursery? Antibiotics do disturb the microbiome of the baby, and that causes what we call dysbiosis, a change in the bacterial flora in the newborn infant. I've already told you it's associated with BPD. In other studies, it's associated with necrotizing enterocolitis and later on sepsis. That is antibiotic treatment, which is prolonged, which means more than 5 days. This is now an older study by Michael Cotton, which shows the number of days on antibiotics increases the odds ratio for NEC in almost a linear fashion. The longer duration of antibiotics, the greater the risk of necrotizing enterocolitis. This is a meta-analysis by Pam Anu looking at the GI flora in babies who developed necrotizing enterocolitis, shown on the right side over here, versus babies who did not develop antibiotics, who were matched for risk factors and birth weight. So, on this slide, the blue color represents gram-negative or proteobacteria. The golden color represents gram-positive bacteria or Firmicutes. And what they showed, looking at multiple studies, is that prior to the development of necrotizing enterocolitis, there was an increase in gram-negative bacteria in the bowel of these babies and a decrease in the number of gram-positive bacteria. And a similar correlation has been made for BPD. These are full-term babies who are intubated for other reasons. The proteobacteria gram-negative are shown in blue. Here is ELBWs with no BPD, and clearly ELBWs with BPD have a higher risk or have a higher incidence of gram-negative colonization. Just to point out that treatment antibiotics can have long-term consequences beyond the NICU for complications such as asthma, diabetes, atopic dermatitis, childhood obesity, and bacterial resistance. Do infants require 5 to 7 days of antibiotics even when the blood culture is negative? Well, that duration of treatment probably came from Constantine the Great, who defined a work week as 5 to 7 days. And that sort of was convenient for a duration of antibiotic treatment. A week back then was considered a Constantine unit. Had he chosen 4 days, our treatment durations would likely have been less. And just to point out that pathogens grow out much quicker, that most pathogens, are growing out by 24 hours, where contaminants are growing out much slower. And this is a small retrospective observational study of babies only being treated for 24 hours. And they chose a population in this retrospective review of babies 33 to 34 weeks, so it's not tiny babies. And their rationale is most antibiotics will remain therapeutic much longer than 24 hours, and most pathogens will grow by 24 hours. So they had 414 babies divided for sepsis, and antibiotics were stopped in 24 hours in 196 babies. They looked at outcomes, and interestingly, fewer babies in the 24-hour group had antibiotics reinitiated within 7 days. So if anything, it looked like there was fewer days, fewer instances of reinitiation of antibiotics. And limitations, small retrospective study. So my conclusion, babies with clinical signs of sepsis who look sick should receive empiric antibiotics. If they're critically ill, the antibiotics should be continued for at least a week, depending on cultures. Antibiotics should be rapidly discontinued if the blood culture is negative and the baby is doing well. Preterm infants at lower risk for infection, mostly delivered for maternal indications, can be managed without antibiotics.